Hey y'all, good afternoon and welcome back to the channel Help for Docs. I'm Toni Appelberg-Parks, your risk adjustment and CDI educator, and today we're going to dig into a change that came through in the 2026 rule year that I think a lot of people are maybe misreading. And this has to do with community health integration or otherwise known as CHI, or the code G0019. So first, let me explain why this is important. CMS renamed something in the CHI descriptor for 2026. They took the phrase social determinants of health, known as SDOH, out of the initiating visit requirement, but they replaced it with a new term called upstream drivers. And I've seen more than one practice read that change and assume that the underlying requirement just went away, and that's just simply not the case. It didn't. The name changed. The requirement did not. And if your documentation habits don't catch up to that distinction, you're creating a big audit risk for yourself, for your practice. So in this video, I want to walk through exactly what changed, what didn't change, who it affects, and what you should be checking before you bill your G0019 going forward. So let's go ahead and get into it. But of course, the lawyers tell us we have to get into our little disclaimer before we start on the content. So just remember the videos for educational and informational purposes only. It's not legal advice and is not coding compliance advice for your specific practice or your specific payer or any specific encounter. Regulations do change sometimes quickly. So I implore you to please verify anything you hear today against current CMS guidance and against AHIMA, AAPC, and ACDIS resources before you apply it to your own documentation or billing decisions. You may be watching this months or even years down the road, so very important. And nothing here is a substitute for your organization's own compliance review process or your legal counsel. So, okay, with that said, let's get into what actually happened with CHI for 2026. So let's start with what CMS actually did, because this is where the confusion begins. For 2026, CMS changed the descriptor language for community health integration services under G0019. Before this year, the initiating visit had to identify what the rule called an unmet SDOH need. SDOH meaning social determinants of health. And that specific phrase, unmet SDOH need, was the trigger. Without it documented, you didn't have a valid initiating visit for CHI. Starting in 2026, CMS replaced that phrase. The new language requires the initiating visit to identify upstream driver or drivers that interfere with or present a barrier to diagnosis and treatment. And CMS was pretty clear about why. They described the new term as more comprehensive, and they're specifically calling out things like smoking, poor nutrition, low physical activity, substance misuse, and what they describe as potential dietary, behavioral, medical, and environmental drivers. So I want you to notice what happened here. The words changed. The scope of what counts, I guess, arguably got a little broader, since upstream driver is intentionally a wider net than SDOH alone. But the core mechanism, a documented barrier that has to be identified at the initiating visit before CHI services can begin, that mechanism is still fully in place, okay? Didn't go away. And that's the piece I want you to hold on to, okay? We'll get into it on the next slide. Okay, so really sit with this. This is where I've seen practices getting themselves into trouble, okay? Somebody reads a summary of the 2026 changes, sees that CMS removed SDOH language from CHI, and jumps straight to the conclusion that the barrier requirement is gone, that the initiating visit no longer needs to document anything like that. That is not what happened. And it's an easy mistake to make if you're skimming a headline instead of, unless you really get in there and dig into the descriptor change, okay? Make sure you understand. So that's what I'm trying to help you do. So here's what's true instead. The gate is still there. The initiating visit still has to identify a specific barrier that is interfering with diagnosis or treatment. And that documentation obligation, that never left the rule. So what changed is the label CMS put on that category of barrier. So upstream driver is simply their broader term for essentially the same kind of thing SDOH was pointing at, but it's just with more named examples and a little bit more flexibility in what qualifies. So the real risk isn't in the rule itself. The real risk is how practices interpret the rule. If your team reads SDOH was removed as being the requirement was removed, that's going to show up, of course, in your work and documentation, and that's the kind of gap an auditor will find because your documentation is going to miss the exact thing that G0019 still requires. So as you're updating templates, updating training materials, updating anything that references the old SDOH language, make sure the message that goes out to your clinical and coding staff is precise. The term changed. The requirement to document a barrier absolutely did not change. Okay, so if that's not enough, there's actually a second piece we need to talk about with the 2026 update, because this one at least actually works in a provider's favor, and it ties to the broader upstream driver language that we were discussing. So CMS also expanded the list of visit types that can serve as the CHI initiating visit. So previously your options were fairly narrow. So maybe you caught that when I was listing those out. But now for 2026, the qualifying initiating visits include your standard E&M visit, though level 1 visits performed by clinical staff still do not count. The E&M visit furnished as part of a transitional care management, the annual wellness visit, and 2 new additions. The psychiatric diagnostic evaluation, code 90791, and the health behavior assessment and intervention services, or HBAI codes. So those last 2 are new for 2026. And they're not really an accident. Behavioral health stakeholders had raised a real concern with CMS. And the old rule made it hard for behavioral health practitioners to initiate any CHI services, even when they were the ones identifying genuine psychosocial barriers standing in the way of patients' care, which totally makes sense, right? CMS did listen to that feedback, and the 90791 and HBAI additions are their direct response to that. So, if your practice includes behavioral health services, this is, of course, worth noting specifically because it may open up CHI initiation pathways that your team wasn't able to use before, okay? And just a quick reminder, that still applies across all of these other visit types too: emergency department visits, skilled nursing facility visits, encounters for patients under home health plan of care still don't qualify as CHI initiating visits though. So because those practitioners typically are not the ones providing the patient's continuing care in the following months. So something to keep in mind on that. Okay, a little more good news. Want to talk about who's actually allowed to initiate and bill for CHI services, because that list got a little bit wider too. So let's make sure you have the full picture and not just the core group that you probably were already aware of. So on the core side, of course, nothing has changed. Your billing practitioner still has to be a physician, a nurse practitioner, a PA, a nurse midwife, something like that. These are the practitioners who follow the patient longitudinally and who are able to bill E&M visits, and also who are eligible to bill under Incident 2 rules. So what's new on the behavioral health side is that licensed clinical social workers, marriage and family therapists, mental health counselors can now initiate and bill CHI services directly when the service relates to the diagnosis or treatment of a mental illness. So that's a pretty meaningful addition, because previously lots of behavioral health providers were limited to a supporting role. So now they can actually be the billing practitioner themselves for CHI within that mental health scope. And these three professions are also explicitly named now as eligible, certified, or trained auxiliary personnel. And this means that they can furnish CHI services under the direction of a supervising practitioner, even in cases where they're not the ones billing. So, depending on your practice structure, this could open up a little more flexibility on both sides. Who can initiate the service and who can actually perform the ongoing CHI work each month. So if your organization has behavioral health staff who've been sitting on the sidelines of CHI billing because the old rules excluded them, then you may want to revisit that with your compliance and coding team now. Okay, so let's see how it all comes together in practical ways. So if you're reviewing charts or updating workflows for G0019 under the 2026 rules, you should be checking these 4 things. The first one, name the specific upstream driver. So we don't want a vague reference to social factors, but an actual specific barrier that's interfering with the diagnosis or treatment of this patient. General wellness language or a passing mention that a patient has some social challenges, quote unquote, is not going to hold up. So you really have to be specific here. Second one, confirm the billing practitioner is the one who identified it. And this is a detail that is easy to overlook. Only time spent addressing a driver that the billing practitioner identified during the initiating visit counts towards the CHI service. So if auxiliary personnel identify an additional need later on their own without the billing practitioner's involvement in that, it won't count towards fulfilling the code requirement. So that's why that's important. Third one, match the initiating visit against the 2026 list. E&M, the TCM, E&M visit, the annual wellness visit, psychiatric diagnostic evaluation or HBAI, and remember also ED visits, SNF visits, home health plan of care encounters are still excluded. Okay, the fourth one, verify who's performing the service and who's actually billing it. Important details. Confirm your billing MPI belongs to a physician, MP, PA, CNM, or where applicable, an LCSW, MFT, or MHC. And that any auxiliary personnel who are involved are working under the proper direction and within their scope. You know, it's going to vary state to state, so it's on you to determine that. I can't cover all 50 states here, so okay. So build these 4 checks into your chart review process now while the 2026 language is still fresh, and you're going to save yourself a lot of cleaning up messes later. Okay. So once again, I'm giving you my source list on this very somewhat complicated topic. I want to make sure that you can cross-check these things and confirm for yourselves before you make any changes. And just know that I did also cross-check multiple sources myself. So here's the full list on the screen. I'll provide you links in the video description if you want to go in and read the language yourself, and I do encourage doing that. So as always, guidance can continue to evolve, so before you apply any of this to your own billing, take a moment to confirm the current requirements directly at best place would be cms.gov. Okay. Okay, so here's what I hope you get out of this today. And if you are finding any benefit in this content, I ask you to please like and subscribe to the channel and share if you like. So, but here's what I want you to get from this. CMS didn't quietly remove a requirement from CHI for 2026. They just renamed it, broadened it a little bit, and expanded who can initiate it and which visits qualify. So there's 3 real changes, but the core discipline you've always needed, which is a documented specific barrier identified at the initiating visit, that hasn't gone anywhere, okay? So if there's anything you or your team need deeper support with on this topic or outpatient CDI, HCC risk adjustment auditing, any of that physician education, you can find me at helpfordocs.com. And thanks once again for your time and presence today, and I very much appreciate you. Take care.